I practice out of St. Joe. We have an office in St. Joe on Hollywood Road, and also we have an office down here near Longmeadow. Okay. Just a matter of introduction. I'm from Chicago. I grew up in Chicago, and I trained at the University of Chicago. And then I finished up my training for 5 years at the University of Michigan. So that's where I met my wife, and we decided to live and find a place that's sort of between our two families. So we chose this area in St. Joe and Niles area. So it's an ideal place for us, and I've practiced here now for 18 years. So this is the only job, it's like my first job, and it's the only job I've ever had, really. So that tells you something about how much I like this area. And this is a very sort of casual talk. I'm going to show you a lot of pictures, and if we get some time, we'll show you some models. And if at any time you have a question, please feel free to raise your hand or just blurt out, I have a question, and we'll stop and answer questions. Because I love to draw. I'm a pretty good artist. And so if you have any questions, I'll draw things out, even if it doesn't pertain to this, okay? My whole goal with giving a talk is that I want you to be really educated, and educated in such a way that if somebody else were to ask you a question, you could say, hey, I went to this talk and I can tell you this, this, and this, and have a really good generalized idea so that if you can internalize what I'm telling you, then you could be a good teacher yourself, okay? So I'm going to go pretty simply and go through a pretty broad spectrum of different ideas. And so if you can internalize that step by step, then you'll be able to understand arthritis and learn how we treat it, okay? Because it shouldn't be very mysterious. Orthopedics is rather simple in your ability to understand it. It gets complicated and technical, and we're not really going to go into that too much, but I really want everyone at the end of this be an expert on osteoarthritis, okay? So one of the things that we have in Lakeland that's I'm very proud of, actually, is that the hospital, we are in a consortium. It's called the Marquis Consortium in Michigan. And we are aligned with all these hospitals all throughout Michigan. And we meet at the University of Michigan once a quarter, and we talk about all our results. Because if you live in a small area, you think that maybe you're in an enclave where you can have good results and bad results and not tell anybody. We actually show and share our results with everybody in Michigan. And we can be proud to say that our results are as good as the biggest universities and the biggest centers all throughout our state. And in some ways, we're a lot better than they are too. Okay? So this is a very generalized topic. I'm really going to talk about knee replacements and knee arthritis and hip arthritis, but really these topics are so generalized that it sort of pertains to other points of arthritis too, in your wrist, in your fingers, in your neck, and also in your shoulder. But I'm not going to talk about shoulders too much today, okay? So we're going to talk about it's going to be a generalized introduction to osteoarthritis. So we're not going to talk about rheumatoid arthritis, or psoriatic arthritis, or the autoimmune diseases. But we're also going to talk a little bit about, conservative treatment. So everything you can do to prevent any kind of surgical intervention, all right? So surgery, treatment of arthritis is a stepwise program. So number one, you use pain pills, you use shots, and bracing and weight loss and those things. And then secondarily, you use shots, different types of shots that we have available. And then thirdly, surgery. So we're going to talk a little bit in the first half of the talk about the non-surgical treatment modalities. Then we're going to talk a little bit about surgery, okay? And if you understand the first part of why we have pain with osteoarthritis, then you understand what is the goal of surgery, how we do the best surgery we can, and how we make our surgical results as good as possible, and also for it to last as long as possible so that you don't have to come back and have another procedure done, okay? So what is osteoarthritis? In order to understand osteoarthritis, you have to understand two anatomic structures, and that is articular cartilage and the meniscus. Especially in the knee, you have to understand meniscus. So articular cartilage. Articular cartilage is the covering of most bones at the joint surface. Okay? So when you look at a chicken bone, you see the nice glistening tissue that surrounds the ends of the bone, and that's the articular cartilage. articular cartilage sort of looks like Swiss cheese. It looks like a very slippery type of a structure that has little holes in it where the little cells live, okay? And it's made out of type 1 collagen. So the same type of collagen that's in your ear or in the tip of your nose. And it's solidly bonded to the bone. So in a sense, it's like, it's a cap over all your bony structures at the joint level. So like I said, when you look at it, it sort of looks like a coconut. So when you open up a coconut, you see that nice, white, soft coconut meat. That's what articular cartilage sort of looks like. But then also, it sort of looks like Swiss cheese because that collagen matrix, within that collagen matrix, if you look at it microscopically, you won't be able to see it with your naked eye. But microscopically, there are little holes, and there are little cells that produce the proteins and keep this articular cartilage alive. And then there's a fibrous structure too. Now that third picture over there is a picture of a boat, okay? But it could be a Corvette as well. So when you see what a Corvette or a fiberglass boat, fiberglass are different, it's like a fabric. And when you get into an accident with a Corvette, you see all the fabric sort of debond. And that's what cartilage is. Cartilage is not just the matrix, but it's also fibers. So this is a representation of what cartilage is and the way that the cartilage is attached to the bone and all the little cells in there, and then the matrix, the protein matrix, then all those little fibers. And the fibers are designed to sort of hold that matrix together and keep the cellular structure intact. So this is a picture of someone's knee getting arthroscopic surgery. So you see that on this part, if you've ever had arthroscopic surgery, that looks like a nice smooth coconut meat, right? But in this part, you can see that the part of the coconut meat has debonded from the bone, and you can see exposed bone. And that's what arthritis is. So people always ask, can arthritis in my left knee spread to my right knee? Does it spread from my knee to my hip? It's not really like that. And some people will say, can you take the arthritis out? Well, you really can't take it out because it's not what you have, it's like what you lose. You lose that covering, and then you've got exposed bone. So this is what healthy articular cartilage looks like. And I'll tell you why that's important in just 1 second. So when you look at it on an x-ray, it's not what you have so much, it's what you lose. So when people say bone-on-bone arthritis, that means that that gap that you don't see on an x-ray is the gap made up of articular cartilage and meniscus in a knee. And when you lose that, you have no gap. So on an x-ray, that gap shows the quantity of cartilage that you have. This is a picture of a hip. So once again, the same type of thing. This is pertinent to all x-rays that you get of your shoulder, of your hand, of your wrist. That gap is the cartilage. When you lose that, then your bones start getting closer together and you start rubbing, and that's where some of the pain comes. So articular cartilage is protected by the meniscus and the ligaments. So we're going to talk a little bit about the meniscus, okay? The meniscus is an important structure in the knee. Not all joints have menisci, but some joints, like the hip, have a meniscal analog. But let's talk about the knee. The meniscus is this structure that actually acts like a cushion inside the knee. So when you look at the knee, the thigh piece is round, okay? The thigh bone is round. And then the tibia, the shin bone, is flat. So when you have something round on something that's flat, you have an area of point contact. So when you have something round on something flat, then this area is in contact. And so that's the part that receives the most stress. And so that's the part that wears the fastest, okay? So what the meniscus does in your knee is the meniscus acts to spread that load out, okay? So instead of all the weight going right in the center and wearing that out, it spreads it over a wide area. It doesn't change the weight at all, but it spreads it over a wider area so you don't wear it out. So the function of the meniscus is to protect the articular cartilage by spreading the load out. So actually, this is an interesting, it's a lot like somebody who has a truck and you have one set of tires, all the weight of the truck goes through that one very small area. But when you have two sets of tires, it spreads it over a wider area. So here's the MRI picture of somebody who has normal meniscus, just like that diagram. It should look nice and black and triangular. And here's somebody with a tear in the meniscus. So when you are, when your arthritis is, when you're young and you have an intact meniscus, it's able to spread the load out. And when you start having tears in the meniscus, then you have more and more load, so that causes an increase in wear. If you don't understand these diagrams and pictures, ask questions at any time. So here's a picture of somebody who has a meniscus tear. So there's a tear that developed over time because you only get one set of menisci, and when you tear it, that's sort of what it looks like. So you have to clean it out, or you can fix it with suture like that. And so the meniscus is very important in preventing the development of arthritis, osteoarthritis. So once again, this is another representation of the meniscus. And I told you, meniscus and cartilage are basically type 1 collagen. They're built sort of the same way, but the fibers inside the meniscus are different. So the fibers act to sort of like a belt, okay? So they go around the whole knee. So the meniscus looks like this. You have one on the inside and one on the outside. The fiber, there's different orientations of the fibers. One of the most important orientations is the one that goes around. And so what that does is it acts like a belt, okay? Or a hoop on a barrel. It holds everything in and spreads the load out so it doesn't grind in one spot of the knee. Any questions? That's why when you talk about these young basketball players and football players and soccer players, when they tear the meniscus, if you have a bad meniscus tear, it's a precursor. You know that they'll probably develop some arthritis down the road. So the ligaments are what hold the knee and give it stability. So the ligaments prevent the knee from sliding because the sliding will cause damage to the meniscus. Okay? So if you damage the meniscus, then you can develop osteoarthritis. So the ligaments work with the meniscus to work and protect the articular cartilage. All the structures inside your knee are trying to protect that articular cartilage. Yes?
I have a question about your kneecap.
Mm-hmm.
What part does that play?
What part does that play? That's a great question. And when you think about what the kneecap does, if you take someone's kneecap out, it's very difficult to climb up and down stairs. Why? Because it's a force multiplier. Okay? When you are trying to climb up and down stairs, what you're doing is you're firing your quads, and then the kneecap is like on a crane. Okay? So here you have a crane, and it's got, see on the cranes they have wires that go across it? And here's a joint on a crane. So when the wire pulls like this, it's supposed to lift the crane up, right? But you never see cranes like that. Those are only hydraulic cranes. Okay? What you really see on a crane is you see something like this. It's got a hinge, and then it's got the other arm, right? But then they've got these things that stick out that allow the cables to have a mechanical advantage so that it can lift a lot more weight. And that's what the kneecap does. If you take out your kneecap, it's harder to walk up and down stairs. It's harder to, you have to use a lot more muscle strength to get around. So that's what the kneecap does. And then the undersurface of the kneecap has the same articular cartilage. So if you dislocate your kneecap a lot and you beat up your kneecap, if you crash into things all the time and hurt your kneecap and damage your kneecap, then you develop arthritis basically of your kneecap. Okay?
When you replace the knee, can you replace the calf too?
Yeah, there was some controversy about that. There's a lot of different ways that people approach that. Some doctors don't replace the kneecap, and there was some discussions and controversies about when you do a knee replacement, should you always need to replace the kneecap, even if it doesn't have much arthritis? Or some doctors will say, if it doesn't have any arthritis, I never replace the kneecap. Well, for the most part, everyone is replacing the kneecap.
Yeah, I wouldn't think they'd be compatible. The human would be different than the person-made one.
Oh, the plastic one? Yeah, you think that what you're saying is that if you put in a artificial kneecap, would you do better than if you have left your own kneecap alone? Well, that's the thing. So you may look at a kneecap and say that it looks very healthy, but sometimes you won't know how healthy it is until you check it at with a microscope. Because like I told you, those holes, let me tell you a little experiment that they did. they got little beagles, okay? And they got their beagles are asleep. And then they got a little hammer, and then they swung the hammer down, and they cracked the kneecap, okay? So the beagles had the broken kneecaps, all have arthritis, okay? But then, instead of hanging the hammer as high, they would hang it a little lower, and then they would let it go. And the beagles would not have a broken kneecap. But those beagles still got arthritis. Why? Because the Swiss cheese concept, where you have little cells living inside, you don't have to break the bone to create arthritis. Sometimes if you damage the bone, the cartilage, and the little cells inside the Swiss cheese, the cartilage, they die, then you develop arthritis too. So it doesn't always have to require a lot of trauma in order to develop arthritis. Sometimes it's just, it's a, and for the most part, it's a degenerative process. So over time, and I'll explain that to you in just a second, over time the cellular function of the cells gets diminished, and then the matrix gets diminished, and the articular cartilage doesn't work as well. So any questions about the ligaments? So people always say, I have an ACL tear and I got to go get it fixed so I can play sports. No. You don't get an ACL tear and fixed so you can play sports. You get an ACL fixed so that it protects your meniscus, so that you don't get arthritis when you get older. That's the way I look at it. And when you think about it, when you tear the ACL and you have these young athletes, they go back and they want to play sports again, when you look at the statistics, it's not as high as you think. You think everybody who gets an ACL tear goes back to the same level of sports? No. It's like 50%. It's not as high as one thinks. So why is cartilage so important? Why do you have to understand cartilage for you to understand the development of arthritis? It's because articular cartilage acts as cushions, and it's neuropathic. It's like the enamel on your tooth. When you had healthy teeth and you're really young, that enamel protects your tooth. So you can eat some ice, you can crack an ice cube with your teeth, and you don't even feel it. And when you wear, because the enamel, the outside of a tooth, has no sensation. It's only when you wear that away do you get down to the dentin, and the pulp eventually, that causes the pain. And that's why you get cold sensitivity in your teeth. Well, cartilage is the same thing. The cartilage protects the bone and covers the bone. So when you lose that, you start feeling it in the bone. That's why arthritis pain is a lot like bone pain. It's like a bone-chilling, deep pain. It's hard to sometimes point out where the pain is because it's inside the bone, and bones are not good at telling the brain where the exact location of the pain is. So articular cartilage is neuropathic. If I opened your knee up and I got a little knife and I sliced a little piece of articular cartilage and you were awake, you wouldn't feel it because there's no nerve sensors. Articular cartilage has no nerve sensors. Okay? So articular cartilage also is like a sponge. When you have a nice, brand new wet sponge and you have a mess on the kitchen floor, you throw the sponge down and it soaks it up. And when you squeeze it, it carries a lot of water, and when you step on it, the water gets squirted out, right? That's what happens with articular cartilage. Articular cartilage is like a sponge. And when it's healthy, and when your cartilage is young, it could sop up a lot of water, and that's how it acts as a cushion. One of the ways it works as a cushion. Because when you step, every time you step, water gets squeezed out of it, and then when you let go, water gets sucked back in. And as we get older, it's the difference between a brand new sponge and an older sponge. So when you get older, it doesn't hold as much water, and every time you take your foot, you step down, it doesn't hold as much water, so water sort of runs out, but when you take your weight off of it, it doesn't soak the water back in as fast. Okay? So pain is derived. Pain, I can't show you. If you said to me, show me a pound of pain. You can't show a pound of pain. Show me a foot of pain. You can't measure it, right? Pain is a perception, okay? Pain is what the fibers tell your brain. So that's why when you injure your articular cartilage, it doesn't hurt. But when you lose the articular cartilage and the bone behind it gets swollen and gets injured, that's where you have pain. Because the bone has nerve fibers, okay? And the nerve fibers in bone are not as well myelinated as nerve fibers in meniscus. What's myelination? Well, nerve fibers have insulation on the outside. If you have an electrical cord with a lot of insulation, the electric current moves a little bit more efficiently. When you have an exposed cotton wire, I don't know anything about electronics, by the way, the transmission isn't as good, you see? So that's why when you damage the meniscus, because the meniscus has a really well myelinated nerve, the sensation hits you real fast, so it feels like a sharp pain. Whereas when you have arthritis pain, the nerve fibers are not as well myelinated, so it's a dull, slower pain. It's an ache, okay? And it's a pressure kind of pain. So what are the conservative modalities? You can use bracing, you can use something to help stabilize your knee, you could squeeze it, you could use the wraps, those cotton, those copper things that people use. That's the sort of the idea. There's no magic to copper, and that hasn't been shown, but any type of brace can help you make you feel better. It gives you a sense of proprioception, okay? Weight loss helps a lot, because every pound that, especially in your kneecap, every pound that you lose is 4 to 6 pounds off your kneecap, especially when you go up and down stairs, okay? Exercise, physical therapy, because that's important too. When you have good flexibility and you have good muscle tone, the muscle is like a spring for your knee. So if you have good springs, like a car, good shock absorbers help take stress off the tires and the wheel. Medications, anti-inflammatory medications, aspirin, ibuprofen, anything, Aleve, anything could work. And then we talk about injections, okay? These are the conservative measures, and then, so I usually say that this is step one. Step one is no poking, just pills, bracing, shoe wear, cushion wear, stepping on cushion mats and stuff, okay? Then the second step is injections, okay? And the injections come in 2 different varieties. Number one is steroid. Steroids are like an aspirin pill. You grind up it's like almost like an aspirin pill. It's like grinding up an aspirin pill and putting it inside your knee. It calms down the inflammation. It's like putting out a fire. Then there's viscosupplemental injections, and that's the injections that you hear about that are made from proteins, and some of them are made from rooster combs. So people call them chicken injections. So that's a lot like getting an oil change. What that does is it replenishes some of the lost proteins. Like I said, if you have a sponge that's not as new, it's like trying to replenish some of the lost proteins inside that sponge so it functions better.
Rooster combs, really?
Yeah, it's a protein. It's hyaluronic acid. And the easiest way, I think, in the past they used rooster combs. Now they use more of, it's more made from test tubes. Okay? So there's all these different kinds of injections. Synvis, Hyalurgan, Soup Parts, there's all these different companies that have come up with all different variations.
And so these are synthetic?
Some of them are synthetic now. Yeah.
Do they use stem cells yet?
Stem cells. Stem cells are the newest class, probably, of injections. The thing about stem cells, I actually do have a lot of hope in stem cells, but not in arthritis, okay? Stem cells, basically what this is you get your blood and you spin it down. And when you spin it down, you get the white cells, okay? Why are the whites? Because you get 3 different parts, okay? So you spin down your peripheral blood. And so you get serum on top, and you get a little layer of white cells, and then you get your red blood cells. So then they pull this out, and then they inject it into your tendons. That's the newest thing, PRP, platelet-rich plasma. Okay? And what PRP is that it's at those white cells. Why? Because red blood cells, their job is to carry oxygen, right? Right? And the serum has sugar and water and stuff. It's this layer where there's a lot of platelets and white cells that actually fix things. So people are beginning to give those injections in tendons and different parts of your body that need the fire department to go in and fix things up, right? The problem with the knee is that when you inject it in the knee, there's no proof that it can go to the right place and replenish the articular cartilage that you lose. So
Even if it's injected there?
Even if it's injected there. Yeah. And I always tell people it's like if you have a road with a whole bunch of potholes and you have a B-52 flying overhead with a bunch of asphalt and you dropped a whole bunch of asphalt down, that's not going to fix those potholes. It's just going to go everywhere.
No, I don't see that as being the same. If
It's-
you're sticking something right in there, why isn't it going right there?
Because it's a lot like, okay, it's like if you have a pothole, okay? You have one discrete pothole. We can fix those areas where there's a discrete area of cartilage. I didn't go into that too much, but if you have a small area of your knee that has a little crack, so this is all cartilage, and you lose a little chunk of cartilage right there, okay? You can actually treat it like it's sod. Take another piece of cartilage and bone from another part of your knee that you don't put a lot of weight through, and then you could transplant that right here. Okay? But the edges all have to be perfect and sort of fit together really nicely. Okay? And that's, it's called an Oates procedure. You take a piece of cartilage and a bone, and you put it in a different part of the knee that shares a lot of weight. But the problem with that is that when you have arthritis, you don't have discrete areas like that. Okay? When you see what arthritis looks like, it's wide open areas where the cartilage is completely destroyed. So, yes.
Then why does the other stuff work?
Why does the other stuff work? Because, well, they didn't say all the other stuff work. Steroids is like an aspirin pill. If you take an aspirin pill, it usually helps with the pain. And if you put the aspirin pill and you sort of, steroids, I don't want to confuse you, steroids like an aspirin, and you put it inside your knee, it calms down your chemical inflammation. Okay? So when you have damage inside your bones and cartilage, your body says, hey, let's fix this. So it releases these chemicals. And those chemicals cause inflammation. And inflammation is the way your knee talks to your brain. And inflammation makes it hurt, so you don't want to walk on it. Well, if you want to heal something, your knee is saying, let's take a little break. And so it sends pain fibers to your brain, so your brain knows not to gimp on it a little bit. That's how it works, So what cortisone does is it shuts that down. So you say, I know it's going to hurt, but the damage is already done, so you just sort of say, hey, let's continue to function so I'm not in pain all the time. That's what steroids do. Now, the viscosupplemental treatment, that's controversial. Some people think it doesn't work. And a lot of people, a lot of doctors just stop offering it because the companies will tell you it has it works on 70% of people with 70% of the pain. I never see that. I only use it if you try the cortisone and it doesn't work that well and you really aren't interested in getting a knee replacement. I try that. And in some very few select patients, it does work, but it's not that common. And the PRP, there's so little evidence for that, insurance companies won't cover it. You have to pay out of pocket. It's pretty expensive too. Go ahead, you had a question first.
I was wondering if the cortisone is a steroid.
Cortisone is a steroid, yeah. Mm-hmm. Yes, sir.
Dr. Sohn, are they trying to develop like artificial meniscus or artificial cartilage that you can put in there, or is that just science fiction?
They are trying to develop that. The problem is that you got to get the living cells in there, and you have to create the matrix, and then how do you put them in? Okay, so it's like if I took my belt off and I gave it to you, and I said, wear this belt like I wear it. It's not going to maybe hold himself up. We do meniscus transplantation too, but you have to size the meniscus perfectly, okay? And if you can size them perfectly, which is a tougher task than one would think, then because it has to work. It's a really tightly woven and very, very. It's difficult to make that fit as good as one would think.
And the same way with cartilage, are they working on artificial?
They are.
Or is that just another?
And going back a little bit, if you have a discrete area like this that's broken off, one way to treat it is with an Oates procedure. There is another procedure where you take cells and you take the chondrocytes and you give them steroids. Well, I say steroids, but it's not really steroids. They give them growth factors to make them bulk up, and then they multiply, and then you create a little tarp made with periosteum. Then you inject the cells into that area, and so the cells can actually sort of grow and live. But once again, that's not really the case with osteoarthritis because you have to have a discrete area. And most people with arthritis, it's a wide open area. If you had a small pothole in the middle of the road, you can throw some asphalt in and you'd be good. But if the whole road is beat up and pockmarked and stuff, that's not going to work. Any other questions? Yes.
If the steroid isn't effective,
Mhm.
can it be shot into the wrong area?
If the steroid is not effective,
Yes.
can it be shot into the wrong
it-
area? What do you mean by that?
Was it?
Injected?
So you want to know what if I got a steroid injection and it wasn't in the right area and I didn't get benefit from it? Maybe it's in the wrong area, or did I not get a good shot? Or did the steroid not work? I always do this. When I inject a steroid injection in your knee, I'm very careful about that, okay? And even in the shoulder, the knee is an easy place to inject, to be honest with you. But what I always do is I always put numbing medicine inside the knee, and you feel as it goes in, I'm slowly pushing in the numbing medicine, and then all of a sudden the numbing medicine just runs in. So that means that you're in a potential space, okay? And then I put the steroid in. And sometimes I put a little bubble in there too. And if you put a little bubble in there and it gurgles, then you know you're in the right space.
Are you serious?
Yeah.
What about the hip?
The hip?
Yeah.
The hip is an area you can give a steroid injection to, okay? And the hip's a really big field. And if you want to spend another couple hours, I can really talk about that too. But the hip, we don't really give a lot of injections. You can, but the hip is a place where we only give injections if we want diagnosis. Now, what does that mean? Let's say you have somebody with knee arthritis, and you have somebody with a bad back, and they say the hip hurts. You go, I don't know. Where are we going to start here? So you give a knee injection. It didn't help you. And then maybe you get an MRI of the back, maybe you get an MRI of the hip, but then you can get a hip injection. And you say, I got a hip injection, and it made me better right away, then you know it's your hip. If you get a hip injection and it doesn't work, maybe it's your back. You got to start looking at your back, you know? So hip injections are harder to do, and so we don't offer them that much. Because sometimes when you get somebody and you get an x-ray and it shows arthritis and you do a proper physical exam, it'll tell you. You know, common things happen commonly. But if somebody has arthritis in their back or a pinched nerve in their back and you say, where could this be coming from? And your arthritis doesn't look that bad and your exam's sort of equivocal, then you get a hip injection. You can do that. We do shoulder injections. We do lots of different types. So there's two benefits to the shots. One is therapeutic, so it makes you better and you feel happy. Number two, it's diagnostic. So if the injection doesn't work, like you said, maybe it's in the wrong spot. Well, I tell you, sometimes we do things to make sure that it's in the right spot. But if it doesn't work, then you have to say, hey, maybe we're barking up the wrong tree and we're going to try something different. Any questions about these conservative measures?
Are there any side effects to the injection?
Right. Number one injection. This steroid, if you're diabetic, well, anytime you put a needle in somebody's joint, there's a risk of infection, any injection, even if you put saline in there, okay? But steroids can actually raise your blood sugars if you're diabetic, and also the risk of infection can be a little bit worse, but knock on wood, we don't get it too often. The other thing about steroids, if you get it real close to the skin, sometimes causes skin discoloration, sometimes causes fat atrophy. It sounds good when fat atrophies, but it doesn't look so good. It creates like hollow areas and stuff. It's not the best looking thing. The viscosupplemental treatments, there's not a lot of side effects. Some people can get a reaction to it. Some of the older injections, people get what's called a pseudo-infection reaction where your knee gets all red and swollen. But some of the newer ones don't do that anymore. And the PRP, that's your own stuff getting injected back into you, so you're not going to have a reaction to it necessarily, but it's expensive. It hurts. It's alert. You get a reaction in your pocketbook. It's like $2,000. I think it's like $2,000, $5,000, depending on what you get. So,
And
yes.
Medicare probably doesn't.
No, it will not. Your insurance will not pay for it. Yes.
With the steroids raising your blood sugar, is that a temporary thing?
It's a temporary thing. It's a temporary thing. Yeah. And so if it works for you, I always do this. If you get a shot and it works for 6 months or a year, you get another one. You can keep on getting them as long as they work. But the first one's always the best one. You can get about 3 or 4 of them a year, but the first one's always the best one. So if the first one lasts 2 years, you can keep on getting. Second one will last a year. Third one maybe 6 months. So pretty soon, little by little, the efficacy drops a little bit. Any other questions on this? So Yeah, so short-term effect from arthritis pain. Viscosupplemental treatment. Some studies say that there's no benefit. And there are a lot, like the Mayo, they don't give injections, viscosupplemental treatment anymore. And PRP, once again, this is a PRP. You get a buffy coat right there, and that's what you inject in. You know, I have a lot of hope in that, but it doesn't work so well for arthritis. Like I think it can work for some tendinitis, some specific tendinitis and tendinosis. So PRP, very controversial. It's safe, but it's not been proven. So let's talk about surgical treatment. So surgery entails either knee. Let's talk about the knee because that's let's use that as a poster child for arthritis. But you can do knee arthroscopy. You can get partial knee replacement, unicompartmental knee replacement, total knee replacement. And in terms of the hip, you can do hip arthroscopy, and that's a huge topic, and also total hip replacement. So this is a picture of a total knee and a partial knee. Now, what is the difference? Well, most people, 75% of people have arthritis in the inside of their knee because I think most people are a little bow-legged. You know, you're born a little bow-legged. So most of your weight goes to the inside. So that wears out the fastest, okay? So when you have arthritis in the inside of your knee, you have an intact ACL, and you have no arthritis in your kneecap, and no arthritis on the outside, we put an implant like this in there, okay? It's a real quick operation. You save your ACL, and you have to have an ACL to do it. So in essence, here's a little model of somebody who has arthritis. So this is the worn and cracked cartilage. What we do is we shave away the shin bone, like that, a little wafer of it. And then we got a piece of metal, and that's glued into position, okay? So these are the principles that we're going to talk about over and over again. So think about a tooth. You wear away the enamel, what's left? The dentin, which is softer and which is sensitive. You shave away the cartilage, the bad cartilage and the bad bone, and you're putting something in there that's securely seated, just like a filling, you know? Just like a crown. And then we shave away the bad bone and cartilage because that's where the nerve endings are, right? And then you put in something that has no nerve endings, a piece of metal. Now, and then in this particular case, we put in a little piece of plastic. And this is called the Oxford knee. Now, not that I'm touting it, but this is what we use. I like the Oxford. It's one of these things where the plastic acts like your own meniscus. So this is for people who have only medial-sided arthritis. Can you do this on the other side? Yes, there is, but no, I don't think too many people do it. And can you do it on your kneecap? Let's say you had a bad car accident and you broke your kneecap and you're 45 years old and you have kneecap arthritis, or your kneecap slipped out a bunch of times so your kneecap is really worn. Can you do this partial knee replacement just for the kneecap? Yes. But this partial knee for the medial side, you know. So the principles are, you take away the bad cartilage and bone, you get something that's inert, metal and plastic, and it's glued into position. And once it's glued, it's solid. So there's no shaking. And so the bone is sitting there all happy because it doesn't feel that pressure and that pressure sensation of being pounded and bruised. That's the principle of any kind of arthroplasty. You're putting a neuropathic joint in there. Neuropathic means no feeling, right? Just like the cartilage, no feeling. That's what you were trying to do, putting something that has no feeling so it doesn't hurt anymore. Yes, sir?
So when you do the partial, there's no replacement of the kneecap?
No replacement of the kneecap.
Okay. If you do the complete, there is a replacement of the kneecap.
There is a knee replacement. You don't have to, but some people still don't, but most of the time we do. Almost all the time.
Partial, no, full?
Yeah, because think about it. Think about this. Here, perfect. That's a good example. So you've got, with a full knee replacement, you're taking away all this bad cartilage and bone. You're putting all this plastic and metal stuff in there, and then you decide not to replace the kneecap. Well, that's still articular cartilage and bone, right? Now, if your articular cartilage is perfect and healthy and nice and thick, maybe it's it works as a neuropathic joint. But if it's not, then you're going to feel pressure and pain in the kneecap too. So that's a judgment call, and I think for the most part we replace all kneecaps.
It just doesn't make sense not to.
It doesn't, the kneecaps don't fail that much. You know, that's a little secret about knee replacements. When knee replacement starts going, where does it go? It doesn't go in the kneecap usually. It goes in the shin bone. Yeah, the shin bone's where you start just noticing looseness and stuff. Okay? So, any other questions? I'm glad you're asking a lot of questions. This is good. Yes, ma'am.
Why can't you fix it if it's on the other side, on the outside?
On what outside and outside?
On the outside of the knee as opposed to the inside?
Because you can. It's just it's a different kind of implant. You can.
Oh.
Yeah. And actually, you know, like I said, 75% of people have arthritis on the medial side, 25% of people have arthritis on the outside, and when you get to the outside, those results aren't as good as medial-sided arthritis. So,
How about for hips?
your hips? Let's talk about the hips in 1 second. So we're going to do partial knees, total knees. Any questions on partial knees? Okay. Total, yes.
If you have a partial knee,
Mm-hmm.
is there longevity to that?
Oh,
Or is
yeah.
there eventually a
Okay.
possibility that you have to have?
Yeah, sometimes you do have to. That's why I like this knee implant so much. Because when you look at a partial knee, partial knees, most partial knees out there on the market have a certain wear rate. Okay? So we're going to talk about failure now a little bit. Why do things fail? So when you have a partial knee, you got a piece of metal that you're shaving off and putting in, okay? And then you've got a piece of metal that you're gluing into the shin bone. And then you have a piece of plastic, right? So remember I told you the plastic is locked in. Maybe I didn't say that, but you lock the plastic in. So the thigh round piece rolls back and forth. So all the wear goes right there, okay? Now this implant is called the Oxford knee. It came from Oxford, England. And what's different about that is that when you shave away the round thing, and you shave away the shin piece and you put a metal in there, that is a floating piece of plastic. And because it's floating, the wear rates are less. That's why I like it. Because most of the time, it's about 0.1 to 0.3 millimeters of plastic that you wear every year. So you wear that away, and those little pieces of plastic go around your knee, and what does it do? It's like creates havoc. It creates inflammation. And inflammation, when you develop inflammation, it starts debonding. It reacts against the bone. Because it can't, you know, when you have a reaction, it's not going to eat the plastic. It's not going to eat the metal. But the reaction causes the metal to start loosening. So that's one of the ways that we think implants fail. That's called aseptic loosening. In other words, it's not infected, it just wears, and those little plastic particles create a mess. Okay? But this implant has a 0.01% wear per year. So the plastic wears a little bit slower, a tenth as slow, okay? And so you could put in really small pieces of plastic. You know, most people, when you get a knee replacement, the plastic's about 10 millimeters. It has to be at least about 8, they used to say. Now it's like 9 to 10 millimeters at the thinnest, okay? But these things, you can put in like 5 millimeters and 3 millimeters. It's really thin because the plastic doesn't wear as much. That's why I like the Oxford unicompartmental knee, okay? That's what we use. I've used it for a long time. I really like it. And then you say the longevity. Well, in the studies, when they first came over from England, it did really well. But then people, you know how when something does really well, they say, let's use it for the outside of the knee. Let's use it for this. Let's use it for everybody. And then it didn't do so well. But if you do it for the right indications, it's about 15 to 20 years longevity. And the Australian registry has a really good, a registry is like everyone who gets a knee replacement puts their name in a list and we figure out how long the whole country, everybody who got a knee replacement in that country has it. So in Australia, they have a really nice registry of Oxford knees and it does really well, 15 to 20 years. So. Oxford partial knee replacement. I don't want to go into brands so much, but you know, because I don't want to sound like I'm selling something.
Even though you are.
You know, for the most part, what you want out of this is information, and I'm really trying my best to teach you general principles that apply to a lot of things. Okay, we don't have to talk about the shoulder because you know, in the shoulder you have articular cartilage, same type of thing. You wear out the articular cartilage, and you got the bone. It's a suck on a tooth, and so it's like that's how you get shoulder replacement. So you don't have to talk about the shoulder because it's very similar to everything we talked about so far. Okay? So this is somebody with medial-sided arthritis. You get a partial knee. There's a picture of a partial knee. This is a total knee and a total hip. Same type. Let's talk about a total knee, okay? A little bit. So you have wear on the medial side or the lateral side or the patellofemoral joint. Same type of thing. We use special jigs that smooth away the bone. Put a metal piece that's glued into position. And I'm going to talk about glue in a little bit too. And then we use like carpenter's jigs to smooth away perfectly the bone, and then you put a metal piece on there, and then the plastic piece goes in between. You don't have metal on metal in knees. It's always plastic rubbing against metal, and then the kneecap is usually plastic.
Is it computerized?
Yeah, that's a great question, and we're going to talk about that in 1 second, because what we want is you get better and better and better. And this stuff started in the 60s, you know, with Dr. Charnley in England, okay? And he started doing hip replacements and he started doing knee replacements, and it really changed everything. And so, and people did great, okay? But then you start saying, how can we make people do better and better? And that's where computer surgery is one of the things that materials, we try to get better materials, better plastics, harder plastics. So, you know, if you the knee replacements from 20 years ago is very similar in many ways. The metals are pretty much the same, the plastic's a little different, and the techniques are a little bit different because we use more computer navigation or robotic surgery, or we use stuff like these things. If you want me to go straight into this, I could talk about this for a long time too. These are custom-made molds, like, and that's another way that it's, you know, maybe, now I'm not saying it's better than computer surgery, but it's another way of doing things, okay? And I'll show those to you. So this is a hip replacement. So knee replacement, any questions? Same principles. Shave away bone, bad cartilage. Apply a neuropathic agent, metal, plastic, and then you glue it in place. Okay? How long does it last? 15, 20 years, usually. Mm-hmm. Yes, sir?
When you're putting in those parts, are they one size fits all?
No. Everyone's different. Like, you know, my knee is probably going to be, you know, bigger than your knee, and your knee might be bigger than my knee. So we size it. We size it. And the knee replacement is a lot of sizing, because when you do knee replacements, you really have to pay attention to the ligaments. So you don't want to stuff something in there and tighten up the ligaments so that it hurts. So you have to size this very carefully. And if you want, we could, you know, basically what you do is, let me just show you real quickly what we do, okay? So you make the cuts based on computers. What we do in our hospital is computer navigated knee replacements, okay? You use computers, and I could show you. I don't have a good video of it, but I'm just going to show you, okay? This is what we do. We put a knee in a room that has this computer array, and then we put different trackers on the knee, and then we put the knee around through a range of motion, okay? And then we got this little, like a pointer device, and we point out and we paint. We call it painting. We paint the articular surface, okay? Then the computer knows, okay, the center of his hip is right here. The knee is right there on the inside. On the outside, it's right there, okay? So then you put the cutting jig on, and it's like a carpenter's jig, and the computer will tell you exactly in 3 dimensions where it is. Okay, in the old days, we used to make a hole in the thigh bone and the shin bone, and we shove a rod there. And the rod will tell you, okay, it aims right at the shaft of the femur, so the hip bone is right there. Okay, so the hip bone's going to be like, you know, if this is connected like that, sorry. If this is connected like that, you want to know where the center of the ball is. And so we used the rod in the old days, but the computer tells us now where things are. And so we make those cuts, millimeter, I mean, we're within millimeters now, okay? And when you make the cut, you have to make sure this gap matches this gap, right? All right? It's like, you know, you guys who work with cars, you know, you work with the feeler gauges. Yeah, it's like you almost use a feeler gauge to make sure this field fits in right there. Yeah, it fits in right there. Yeah. So that's what you do. And that's why when you measure it out to figure out how to put this on, you use specific sizes. Okay? And really with knee replacements and hip replacements, there used to be a time when, when you get a car like a Saab, the starter was on the ground, and sometimes the old cars, the brake was on the left side and the brake was on the right side and the gas was on the left side. Nowadays, all the implants are pretty much the same. So if you say, I want the Cadillac. Knee replacement, it's a lot of the surgery is soft tissue based. It's not just bone. You can't just say, okay, I planned it this way, we cut, and then you put things in there. A lot of it is balancing. There's a lot of ligaments to balance. Yeah, that's a good question. All right, so hip replacement, how do we do this? The biggest question in hip replacement I've been feeling is anterior or posterior. Everyone wants to know what's the difference between anterior and posterior. Is one better than the other? One's not really better than the other. They're about the same. The dislocation rates are about the same. So people always say, well, I want the muscle sparing surgery. They're pretty similar. Do you cut through more muscle when you go through the back? You sort of do. Okay? It's a lot like when you change an oil, change oil in your car. It's easier to go underneath and just get to the filter and the oil, right? Or you can do it through the top nowadays in some cars. Well, it's sort of that way in a sense. When you go through the front, you can do the hip replacement very easily, okay? But if there's a problem, it's harder to fix. You see? You do it to the back, you can do the oil change, you can change the transmission, you can do all this other stuff, right? But when you go to the front, you gotta just make sure that, that's all you're doing. Okay? With the hip replacement, same thing. What do? We take out the bone and cartilage, right? The bad bone and cartilage. So if this were a hip, we'll pop it out to the back, we'll pop it out to the front, cut off the bone, cartilage, shave out the inside, put in a new metal cap, has a plastic piece right there, put in hip bones that are hollow, so put a new stem in there, it's like potting a plant, and pop it back in. That's a model, that's an extra hip replacement. Yeah, you cut, let's say the arthritis was, now obviously on that side, but you cut the bone right here, take the ball out. There was a time when we did resurfacing. Resurfacing means that you shave off the end of the bone and put a little helmet on. Don't do that anymore. That's what we do. Because that was metal on metal, see?
Are you going to talk about the new process?
The new process, the navigation, for the hip, anterior hip, or
Well, it's what I,
oh, MIS? We all do MIS. That's minimally invasive surgery. That means you use small incisions. That's why we have to go to computer. In the old days, you do a hip replacement, the incisions on old hips are like this long. You can see all the way down the thigh bone, you can see the pelvis a lot better. But with navigation, you can use small incisions and not see as much, and actually the computer tells us how to put things in. And that's the next part of my talk. I'm just going to show you what I mean by it and why it's so important. So hip and knee replacements do really well. So our goals are, number one, how do we make them more reproducible? How do we make them last longer? How do we make them more successful? So pain relief is the goal. We're pretty good at doing pain relief. You get a hip replacement 98% of the time, 99% of the time, you think it's much better. Knee replacements, well, similar, probably about 80%. Okay? I'm really happy with the knee replacements. And the other thing too is longevity. You want to make sure things last the longest. So the plastic doesn't wear as much, and the metal doesn't wear out. Okay? So when you think about the longevity, annual failure rate is about 0.5% to 1% a year. That means if you get 100 people, maybe one person out of 100 every year will fail. So 90-95% chance of lasting 10 years, and about 80-85% chance of lasting 20 years. Oh, they're supposed to now last longer than that. And that's what I want to sort of talk about too. The MIS is one thing, and the computer navigation is another thing, and the 3D printed cutting guides are another thing. But I want to talk a little bit about, press-fit implants too. I really like doing press-fit knee replacement. Okay? Because I think that increases the longevity too. So the alignment of the knee is very important. You're talking about a couple degrees here and there make a big, big difference. And then we talk about mechanical alignment. It's like a plumb bob. You want to go from the top of the hip all the way down to your ankle, and you want it to go straight down the middle of the knee. Okay? And what that does is it balances the inside and outside of the knee so that one side doesn't wear out faster than the other side. So you don't. Huh? Oh yeah. The hips are a little different, but the hips are the alignment on the hip is different. Is important in a different kind of way. And I'll show that to you too. Okay? So when you have a knee replacement, this doesn't show you where the hip is and doesn't show you where the ankle is. You can tell. It's just even in the back of the room. You maybe turn the lights down. You can see that it's a little off. You know, it's a little tilted this way, right? And that is not good, because that means that this side of the bone experience and that side of the plastic and that side of the metal experiences a lot more stress. So it's a little imbalanced, see? And so it's probably not going to last as long. In the hip, the alignment is very important as well. The femoral alignment is very important. But the acetabular alignment is very important. Okay? What does that mean, the acetabular alignment? The acetabular alignment is paramount in preventing, number one, dislocation, number two, wear. Okay? So when you put the implant in, and you don't make, if it's too vertical, okay, a couple of degrees, too vertical, then this presses against that area, and then it can become loose. Okay? It's when, I don't want to go too much into dysplasia, but we heard about, like, dogs having shallow hips, right? All right. So if you put the hip replacement in, and instead of being like this, 45 degrees or less, if you put it in too much vertical, guess what? That edge gets a lot more stress. So here's the hip. Here's the cup. Here's the ball, right? When this cup is too vertical, then you get a lot of edge loading. That means that this plastic on the edge here gets a lot more stress. And the rest of the plastic is stress shielded, so it's not getting any stress. So that's why when dogs have shallow hips or people have dysplasia, congenital hip dislocation, like kids who are born with hopping hips, if their hips are if the hip is put in like that, then it wears on that plastic a lot faster. And when it wears on the plastic, what happens? Plastic particles, right? Plastic particles will cause loosening of the metal. That's what you see. It started out good, but look at this. See how the center, can you see how, and your brain's so good at seeing this kind of stuff. The center of the cup is right there, right? And the center of the ball is right there. You see that? Okay. Well, look at this. The center of the cup is right there, right? Where's the center of the ball? It's right there. See, it moved. It wore the plastic out. And then when that plastic, those particles, started going in the bone and causing inflammation, then it started loosening. The metal started loosening, and that's how you have failure. That's where alignment. That's where in the hip, the alignment's so important. So here I am in surgery, doing somebody's surgery, and how do I know how the cup is going to be put? How do I know that the cup's going to be like this versus like that? I mean, you can't even tell, right? The computer knows that. We are doing the operation, and I'm doing this, and I'm putting this in, and as I'm putting this in, I'm looking here, one eyeball is looking at the computer screen. And that computer screen is telling me 2 degrees, 5 degrees, how deep is it, It's like landing like a shuttle, landing on the surface of the moon. It tells you, almost down, change your angle, So that's important in terms of preventing that edge loading. You don't want it to, you want it to be like this, well covered and not edge loaded. So that's where the alignment comes in. And also, we didn't talk about this, but I think the next slide. Yeah, dislocation. If the hip is not put in correctly, and let's say I decide, oh, I'm gonna go this way a little bit, a little further backwards. And then go, the next time you're getting in a car or sitting on getting out of the bed, you go like this and it pops out. Or if it's not on the right angle, or if I decide to go this way too far, the next time you go like this, you stride like that, it pops out. So that's why that angle is so important. And prior to computer navigation, we would sit in the room and we put the implant in and we'd say, make the handle face that little spot in the wall. So we put the handle right there. And that's sort of how you used to do things. You draw lines and all this stuff. But, you know, the patient rolled a little bit this way, or the patient had a funny kind of hip or something. You wouldn't know until after surgery. Computer navigation gives you real-time information during surgery. And it's very accurate information. And it's very precise information. 5 degrees is hard to tell, but on a computer will tell you.
So is it mapping or computer mapping as opposed to any?
Yeah, you do. You do. You actually do. What you do is, okay, here's another thing. So, we put a computer array on the hip, okay? And then we sort of say, okay, this person's laying on their side, and then we move the hip around. It's complicated, but we say, this is the hip. So we take the hip ball out. Remember, we took in the surgery, we take the bad hip out, and we take out the head, right? And so we're looking at the cup right there, okay? Then I take a little feeler gauge, and I paint, it makes a beeping noise, and then it paints the whole thing. Okay? And then after it's painted, then I get, it's called a reamer. Sort of it's a brutal process. And we shave away that bad cartilage and bad bone. And as you're doing it, it tells you you're at this angle, that angle, you're too deep, you're shallow, you're too deep. So it tells you all that information. So you get a nice smooth surface. Robotic surgery is the same too. The robotic surgery is that the drill is connected to the robot. And then the robot will it'll tell you too far, too right, too left. And then if you go too deep, it just shuts off. So that's the only difference between robotics. And the robotic arm controls the spin. Well, when I do it, I'm looking at the screen and I can control the spin with my finger. That's the difference. Robotic surgery is not that much. So the center edge angle, you see what I'm saying? If you have a shallow hip, that angle gets lower. That's what a dysplastic hip is. That's what a congenital dislocation of the hip is. And we try to make sure that when we put that back in, even if you came in with a shallow hip, you're not going to get a shallow hip when you leave. You're going to have a hip that we want to get to about 45 degrees, at least 45, maybe even 40 degrees to prevent you from wearing that plastic out faster. So this is, you see that this is a shallow hip, and I'm just showing you the difference between center edge angles. This is 27 degrees. Anything higher than 25 is good. Less than 25 is 21 degrees. These are kind of pre-operative planning things that we do. Computer navigation, it's like GPS. In the old days, you pull out a map and you try to go, where are we? And you get lost. I used to do a lot of camping in the old days. You go to the compass and you look at the peaks and go, where's that peak versus that peak? And it's very confusing. But GPS is wonderful. So that's what the GPS does. It gives you real-time information. Sometimes when you do like compass orientating, you have to move to the next spot. And then you say, oh, wait a minute. I thought I was there, but I wasn't there. Now I know because I moved, and now the peaks of the mountains are in different positions. So it doesn't give you real-time information. Whereas computer navigation gives you real-time information. It gives you accuracy, and it gives you reproducibility. It allows you to use a smaller incision, not have to see the whole lay of the land because you know where you are in real space. Okay? Early satisfaction because you're not being disruptive, as disruptive. And we think long-term benefits because the implants go in and you don't have I didn't think that was like that post-op X-ray. We know what to expect on the post-op X-ray because we knew what was happening during surgery. I was taking X-ray in surgery. call them? Implants, they can move. Yeah, they loosen up. Computer assisted surgery helps your surgery more precise. Do you understand, does anyone have questions about computer navigation? The GPS? Because you have to figure out what depth you are, and also, so when you get hip replacement, sometimes your hip gets a little longer, and the computer tells you how much longer your hip is, how much shorter the other is. You know, slight degrees of variation can be told, can be picked up by the navigation system. Advanced technology, you don't need CT scans and MRIs, we do it right during surgery. Some systems you do need MRIs and CT scans prior to surgery, that adds more cost. Custom-made instruments, let's talk about that for a second. So these are implants, like a representation of the distal femur. You get an MRI, okay, somebody wants a knee replacement. Remember I told you on the computer navigation, you use the jig. Well, these are custom jigs to your knee. Made for your knee. See that? So you make the incision, and then you get this thing printed up by a computer. And then you put it right on the knee. So you know exactly where it fits. It doesn't move. And then it's got sites where you put pins, and then you're off to the races.
Is that an option then?
I do that once in a while.
Why just once in a while?
You have to get an MRI. Get an MRI. And computer navigation is they're very similar in cost. All of it's cost. Computer navigation, when you think about all things being equal, computer navigation is a little bit cheaper and a little bit more. Because this is like, you know, when you need, it picks out all the bumps and stuff, and then this picks out all the bumps and it will match it together. You guys can play around with it. And so here it is for the shin. So the shin, it's an MRI of the shin, and then you get a 3D printed thing. It's in perfect. Try to rock this. It's not easy to rock. You had a question?
Okay, which one would be more, beneficial to the person that has an arthritic knee?
About the same.
They are?
Pretty close. I would say if you had a race, the computer navigation is a little bit better, but do the 3D printed, it's a little bit faster.
Okay, and can your hip cause your knee to be out of whack to where you would not need to have knee replacement?
Oh, that's a good question. That's a good question. When you, when we do the navigation for a knee, what we have to do is move the hip around perfectly. Let's say you have really bad hip arthritis, and I'm trying to find the center of the hip, and when I do the navigation, I'm trying to find the center. One of the things that we have to have is a hip that moves freely. Now, let's say you have really bad hip arthritis, and it's like ankylosing. It's like every time you move your hip, it's like, you know, what do you call that, Chester? The whole problem, right? And you can't tell you where the center of the ball is, right? That's a situation where you can do with the 3D printed navigation. 3D printed. Now, I want to go ahead. You have
If you have issues with your knees and hips, does it make the condition worse to exercise, like walking or anything, bicycle, anything like that?
Well, overall, you want to try to avoid the kind of things that will continue to damage you, you know? One of the other ways I explain to people what the articular cartilage is the articular cartilage is like the tread on your tires. You know? If you have bad tires, you don't go out joyriding all the time. You sort of try to be a little careful of it. But at the same time, the worst thing you do to your tires is let it sit slow. That's the worst thing. Cartilage sometimes. But in terms of the tires, exercise that's non-impact is probably the best thing to do. Okay? Swimming is probably something that keeps your range of motion, number one. Number two, to build up muscle strength. Okay? Number two. And also for balance and stuff.
Better people say we should exercise to build the middle for surgery, but I never knew what it was.
Oh, what exercise in particular? Well, it's like things like squats, you know? Anything you build up quad strength. The stronger your muscles are, the faster you'll bounce back. That's why when you have, if you're in peak physical condition, like, basketball players, they can get an operation one extra quick. But most of us aren't like that. We don't have a trainer that goes to this, twice a day. Your muscles are not in peak condition. So if you want to get into an operation, you want to try to build up as much strength as you possibly can to get yourself done. Now, is it good to exercise when you have arthritis? I think it's always good to exercise. But there are good exercise and bad. It's a spectrum, you know? Should you dig ditches with a shovel? Okay? Should you run? Maybe not. You know, anything that's impact, pounding on your heart. Walking is a little bit of pounding. So if you said, I love to walk, go ahead and walk. Okay? But if you said, hey, I've got a elliptical machine, or I want to go walking, and I choose either one is sort of it's a toss-up, I'd go on the elliptical machine. It's less impact. Bicycle is less impact.
Stationary.
Is that?
Stationary bikes?
Stationary bike's fine. Keeps you moving. Yeah, it's a good. Oh, but we're also talking about how to maintain strength.
Right, but I mean, as far as the.
Your ability to bounce back is
Whether
definitely.
you jog or whether you swim, it doesn't really matter as long as you pick up.
Yeah.
But the stationary bike is the same.
It'll probably cost you anything.
But it will matter.
You're gonna get into it. Oh, one thing else, go ahead.
In a total knee replacement, what's the average recuperation time?
It's about 6 weeks.
Did you cover about how to do it pretty much?
Yeah, I talked a little bit about it. It's very similar. It's very, to be honest with you, a lot of it has to do with, anyone who's heavier, it's always more difficult to do hip replacement or a knee replacement. We actually are beginning to really crack down. If your BMI is over 40, your rates of having complications and having issues after surgery really go up. And also, it makes the surgery much more difficult. So, BMI is a factor. Diabetes control, nutritional status. In the old days, we didn't really, it's not like we didn't care about it. We didn't talk about it very much. But the healthier you were, was it?
We didn't know about it.
We sort of knew about smoking. Smoking is an absolute, if you smoke, but
Okay, I'm gonna have knee replacement over this fall. And I've got some friends who are not doctors, but they claim to have great medical knowledge, okay? Yeah. So here's what they tell me, and I don't know whether to believe in this stuff or not. They said, okay, look, if your parent had osteoarthritis, you'll probably have osteoarthritis. Is that true or
it's
not?
multifactorial.
Okay, that
Let's
is-
say your parents worked on a farm and, they, worked all day long. And, there's a genetic component too.
There is a genetic, so they were right about that.
There's a weight component,
Okay.
How much pressure are you putting on your joints? There is a, injury. Sometimes you get arthritis from post-trauma. Let's say you have a meniscus tear. Like I said, you have an ACL tear, you have a meniscus tear because you played basketball and it never really healed right or it never was fixed. And so you develop arthritis. So it's multifactorial. So,
But there is a genetic
there is a
component.
genetic component, yeah.
They also said, I put down a couple things they say. They said, look, once you have knee surgery, you'll probably have hip surgery. Is that true or not? No, okay. I don't know where they got that at. And the other one, okay, there's one more thing that they told me, and that is they said if you wait too long for your knee replacement, your body's going to start compensating for the pain in your knee. It's going to cause, let's say you're going to have your left knee replaced, and then your body compensates because of pain. Then you're going to have problems with your other knee and your hip, and you probably end up with right hip.
You gotta really tolerate a lot.
Is that true or not?
You gotta tolerate a lot of discomfort. Let's say, in the worst case scenario, let's say you can't straighten your knees out, and you walk like this, okay?
Yeah.
First of all, you're not gonna stand that long, okay? But also, you lean like this. When you walk like this and you can't straighten your knee out, like this, and there are people that come to our office, they can't straighten their knees out. And so what are you doing? You're walking like this. What does that do? It certainly doesn't help your back. And you can't stand as long because, you know, you can't be on guard duty like this. You know, this is the most efficient way to stand, locking your knees. So people can have that problem, okay? And people can have neck problems because of the way they're walking. And they get fatigued out easier too. So is it like, you know, is it travel, you know, if your knee's 65 years old, your hip's gonna be 65. And so maybe it's a coincidence that, you know, you got knee arthritis, you got hip arthritis too. But it's not like, it's not a causative factor necessarily.
Is there a point in time that your knee degenerates to the point that it is not replaceable?
Yeah, I'd like to say no, but sometimes we do get into pretty bad situations. And those are very, very few parts.
So you can wait too long to get
You
replaced?
can wait too long, but not really. You know what I don't like? This is what I don't like. If your knee hurts a lot, and you say, I'm not going to walk around the store, I'm just going to get all of those things that just splatter around. And you do that all the time. Now, your knee's not going to kill you. But if you're not healthy, if your heart's not healthy, you can't stand, you can't even get mail, that's no way to live life. And also, it's not making you unhealthy. It's making you unhealthy. Standing is the best exercise in the world. Do you know that if you sit for more than 5 hours a day, it's worse than not exercising? If I stand all day long and I don't sit that much, I don't have to, I'm not saying you don't have to. You don't have to necessarily exercise. If you sit all day long and then you exercise 3 or 4 times a week, it's not as good as standing all the time. Standing is the new, sitting is the new smoking. I want to talk about one thing that I do that's slightly different and that I really am excited about. And that is, when you do a hip replacement, do you use cement? No, you do not use cement. This cup has a porous shell that's tapped into position. Sometimes we use a screw, sometimes we don't. This stem has a porous surface that we pot into the thigh bone, okay? When Dr. Charnley in England, when he first did hip replacements, he used cement. Cement comes from dentists. Dentists use it for their, they use it for their stuff. So he used cement. But as we go on, 70s happened. What happened in the 70s? In the 80s, we stopped using cement for the cup. We were using metal. But we still cemented the thigh piece. And then we stopped cementing in the thigh piece. When I was a resident, hybrid knees was the gold standard. I'm sorry, hybrid hips were the gold standard, which means that you press fit it. Press fit means you don't use cement, you basically tap it in, press fit it. And then cementing in the femoral component was the gold standard. That's the hybrid knee. Cement, no cement. Then everyone now is pretty much doing no cement on the femur and no cement on the hip. Why do we do that for the knees? We did do that. We did do that for the knees in the 80s. Okay? There's components that come out that have special coating on the back that allows the metal to sit on the bone and the bone grows into the metal. The problem with that is they're more expensive. It's much more technically demanding. You have to make really smooth cuts. You can't make any ruts and pits. And the mechanical alignment was very important. Okay? So there are studies that show that when you cement in a knee, okay, here's a pretty look. If you press fit a knee with no cement, should it last longer than a cemented knee? And when you look at studies that go back and look forward, it's called retrospective study, it finds out it's about the same. But you know what though? When you really slice into those numbers and really look at the numbers, the people who had the press fit knees were younger and more active. Okay? So and sometimes, like you said, when you look at a knee, how long, sometimes, you see knees that last 20 years? Yeah, I've seen knees that last over 20 years. I've seen knees that last almost 30 years. And lots of times they're press fit. And so, if you have good bone quality, you can stand having a press fit knee. I sometimes choose press fit knees on people. What press fit knees do is that instead of putting in a piece of metal, you cut the bone, and then you pop the metal into place, and it's secured very tightly. It's tapped in, and so you have no interface of cement with metal and that bone. So the bone's living. So the bone it grows and changes and adapts and grab onto the metal. Okay? If you put cement in there, one of the problems is that cement, there's nothing wrong with cement. It has a perfect longevity. I just think I like press fit and I feel that it lasts longer, especially on younger, higher men. Because what you do is when you put cement on bone, you've got living bone, and then the cemented bone, which is not a happy bone. You know, cement gets really hot. So that's a dead bone. Then you have cement, and then you have metal on top. So you got, so it's a dead bone sandwich. So what I'd like to do for some people is if your bones are in good shape, if you're good quality bone, you're active, I'd like to press fit knees. I'm doing a lot more of those. It's one thing I really feel like, it's like the holy grail. How do you get a knee replacement or a hip replacement that lasts long, for a long time on people who are very active and are going to, not want to get another knee replacement and probably have, 40, 60, 50 years of longevity, and that's the holy grail. You get closer and closer to it all the time. Mechanical alignment, computer navigation is one thing. 3D printed components, making things line up perfectly is another technique. Materials, better metals, better technique is another.
Dr. Sohn, I wanted to be conscious of everybody's time. It's already about 7:20.
Okay.
I don't know how many more questions or where you're at, but
I'm done with the slides. So I'll answer any questions.
I wanted to thank you personally for coming on down here and giving us time and stuff. But if you mind staying a little bit,
Oh, yeah, sure.
questions, okay? But it is 7:20, and I think you guys are.
Does it feel like you guys learned a lot?
Oh, yeah.